is Dr. Raja from SNS College of Physiotherapy, and I am going to share a case study from an anatomy which you are going to learn, which you are going to practice all over your future from an abduction of the shoulder patient. There is a problem in the abduction of shoulder for this patient. Assume that he is a patient which he is diseased from the abduction, which he cannot able to do the movement of abduction of this right shoulders. Okay, so you know which muscle is mainly used for abduction of the shoulder? It's deltoid, but there are more muscles other than deltoid. The first 0 to 30 degree of the abduction of the shoulder is done by the supraspinatus. We know the supraspinatus, which is located in the upper part of the scapula. The supraspinatus is the main muscle which tips the scapula like this. It tips the scapula and it makes the first 0 to 30 degree of the abduction. And the deltoid, which makes the 30 to 90 degree of the abduction of the shoulder, and the 90 to 180 of the shoulder is done by the trapezius and the other name of the muscle? Serratus anterior. This is the other muscle which is doing the abduction from 90 to 180 degree of the shoulder. Then how we are going to make this case study is, first, if a patient is coming for an abduction problem, they can't be able to lift the arm from here to here, then it's not mainly because of the deltoid, maybe because of the supraspinatus, maybe because of the trapezius, serratus anterior, or even maybe because of the antagonist muscle, which we are going to study in the upcoming subjects like biomechanics and physiotherapy. It will tell you what is the agonist, what is the antagonist. The prime movers, I think you have studied about the prime movers. That is the agonist, which is the main muscle, used for the movement. The agonist is the main muscle used for the movement. The antagonist is the opposite side of the muscle, which is also used for the movement. If the abductor is working, the adductor should also work counteracting the same movement to stabilize the movement. So, if you are having problem with the abduction, it is not only because of the deltoid, but also because of the surrounding muscles. First of all, I said no. There is a patient of a problem with the abduction. The same problem may be because of the periarthritis shoulder of the diabetic patient, but it is not the same. It is a differential diagnosis. It looks like the same disease, but it is not the same disease. It may be different from this disease. In the PA shoulder, we will differentiate it as it's not only because of the abduction, it's also because of the internal and external rotators of the shoulder. But for this supraspinatus tendinitis or maybe any painful arc syndrome, they cannot able to do this abduction movement. For that, we have to concentrate not only on the deltoid but also on the supraspinatus and trapezius and the serratus anterior, which is also responsible for the movement of the shoulder abduction. Likewise, do you know any other muscles which is connecting the hip and the shoulder? Yes, there is the latissimus dorsi which connects the hip and the shoulder. The latissimus dorsi is a big muscle which starts from the iliac crest of the hip bone and which inserted into the humerus, which is inserted in the humerus between the mnemonics, the famous mnemonics for the latissimus dorsi. It is the lady between two majors. The lady which denotes the latissimus dorsi and two majors denotes the teres and the teres major and no, the two majors, the lady between the two majors. What is the another major muscle? One is the teres major muscle. What is the another major muscle which is starting from the upper lip? It's the pectoralis major. Okay. So these muscles are the, what is it? Lady between two major. So what we are saying about the latissimus dorsi. If you are having any problem with your shoulder, we can treat it in the hip because the latissimus dorsi is from the hip bone and also it ends in the humerus. So the problem is in the one place, but we have to treat in the source of the problem. If you treat a problem where it is located, it's not the correct thing. Most time it won't be the same place. It's maybe because of the any other place. So we can first we should assess the patient and we can go for the treatment. If you are assessing it, then the 75% of the treatment is over. If you assess it properly, then 75% of the treatment is over. Then the balance part is your treatment. 25%. It is kind of. So you should think out of the box for treating the patient. Since you are in the first year, while you are getting into the next year, you should know about this. Okay, you will see some of the interesting facts in another video. Thank you.